Welcome to the deep dive. We focus on getting you the essential info you need fast.
Just the key insights, no wasted time.
Exactly. Today, we're tackling Herpes Zoster Ophthalmicus, or HZO. Now, this is an eye condition, fairly common actually, but it can be quite serious. So maybe you're revising for an exam, or perhaps you just want a really solid grasp of HZO without drowning in detail. Well, you're in the right place.
We'll aim for clarity in the high-yield stuff.
That's the plan, our mission.
Yeah.
Nail down the essentials of HZO for good recall. Okay, let's dive in. What fundamentally is HZO?
Okay, so Herpes Zoster Ophthalmicus, HZO, it's a viral infection. The virus is varicella-zoster VZV,
The chickenpox virus.
the very same one. So after you've had chickenpox, the virus lies dormant, and in HZO, it reactivates. Specifically, it reactivates in the ophthalmic division. That's the first division, V1 of the trigeminal nerve.
Okay, V1. And that supplies.
That nerve covers sensation for your forehead, around your eye, the upper eyelid, and even parts of the nose. And the key features you see with HEO are, well, a painful rash and inflammation that involves the eye itself.
Affecting the eye directly.
Yes. And interestingly, about 10% of all shingles cases, which is what VZV reactivation is called, generally actually involve this specific ophthalmic nerve branch.
10%.
Yeah.
That's actually quite a chunk. Really shows why focusing on the eye is so important here.
It does. It's not just a skin rash near the eye structures are often directly involved.
So it lies dormant after chickenpox. What wakes it up? What are the triggers for this reactivation?
Well, the virus hides out in the sensory ganglia, these nerve cell clusters. It can stay quiet for decades.
Right.
Then certain things can allow it to reactivate. The big one is definitely immunosuppression.
Okay, like what specifically?
Things like HIV/AIDS or patients undergoing chemotherapy, maybe organ transplant recipients on immunosuppressants, anything that weakens the immune system surveillance.
What else?
Advancing age is another major factor. As we get older, our cell-mediated immunity tends to decline naturally, what we sometimes call immunosenescence.
So older people are more susceptible.
Definitely. And stress, while maybe harder to pin down scientifically, is often cited by patients and considered a potential contributor too.
So you've had chickenpox, that's the baseline requirement.
Absolutely. No chickenpox, no shingles, no HZO.
And then age or a compromised immune system are the main catalysts. Who should we be most aware of risk-wise?
The risk factors really line up with those triggers. So number one, history of varicella, you have to have had it.
Yeah.
Number two, advancing age. It significantly increases risk.
Okay.
Number three, immunosuppression. Again, HIV/AIDS, chemotherapy, transplant drugs, those are key examples.
Right.
And finally, certain underlying medical conditions, perhaps cancer itself or some autoimmune diseases, might also increase susceptibility.
Okay. Maybe a quick way to remember those main ones.
Yeah, you could think something like age and immune issues make chickenpox HZO. Simple, but covers the big ones.
Age and immune issues make chickenpox HZO. I like it.
Yeah.
Okay, so we know the what, why, and who. How does it actually unfold? What's the pathophysiology step by step?
Right. The process begins when that dormant VZV reactivates within the trigeminal ganglion, specifically affecting the ophthalmic nerve cells.
In the nerve cluster.
Exactly. The virus then starts replicating and traveling down the nerve fibers of that ophthalmic division.
Towards the skin and eye.
Precisely. As it travels, it causes inflammation along the nerve itself, and then where the nerve ends, in the skin of the forehead, eyelid, nose, and in the eye structures, it causes inflammation and damage there too.
So that explains the rash and the eye problems.
Yes, it's a direct result of the virus spreading along that specific nerve pathway and causing inflammation and cell damage at its destination, like it's following a predetermined route.
A very specific, painful route. Okay. Now, if someone comes in with eye pain, redness, maybe a rash starting on their forehead,
Yeah.
what else could be going on? What are the main differential diagnoses?
That's crucial, distinguishing it. You definitely think about, well, simple bacterial or viral conjunctivitis.
Pink eye.
Yes, though usually less pain and no typical rash. Corneal ulcers are another possibility. They cause significant pain and often blurred vision.
Okay.
Sinusitis could cause facial pain, maybe around the eye or forehead. But again, the pattern and type of pain and the lack of the characteristic rash usually helps differentiate.
Right, the rash is key.
And just generally, other causes of eye pain or facial pain need to be considered. But the vesicular rash in that specific dermatomal pattern, that band-like distribution following the V1 nerve, is usually the big clue for HZO.
That dermatomal pattern really points you in the right direction. Got it. How common are we talking here? Is this something GPs see often?
Well, the exact UK prevalence data isn't perfectly tracked, but we have good estimates of the incidence of the new cases each year.
And that is
It's estimated around 1 in 1,000 individuals per year in the UK develop HZO.
1 in 1,000.
Yeah,
Okay, so not rare. Definitely something clinicians will encounter.
absolutely. You'll see it.
So let's picture that patient. What are they typically experiencing? What are the classic signs and symptoms?
Often it starts with the pain, sometimes quite severe pain in the eye or along that V1 distribution, forehead, scalp, side of the nose, even before the rash appears.
Prodromal pain.
Exactly. Then they might notice redness in the eye, maybe it's watering a lot, perhaps blurred vision.
Okay.
And then comes the hallmark, the vesicular rash. Little blisters, basically. They pop up on the forehead, the eyelids, maybe the side or tip of the nose, usually just on one side of the face.
Bilateral.
Yes, respecting the midline. And crucially, it follows that dermatome, that nerve distribution area we talked about.
Right. And you mentioned the nose. I've heard of Hutchinson's sign. What's that about?
Ah, yes. Hutchinson's sign. It's a really important one to look for. It's when you see vesicles, the rash, on the tip side or root of the nose.
Just on the nose. Why is that so significant?
Because the tip and side of the nose are supplied by the nasociliary branch of the ophthalmic nerve. And this same nasociliary nerve also supplies sensation to parts of the eye itself, like the cornea and iris.
Ah, I see.
So if the rash is on the nose tip, it tells you that specific nerve branch is involved, which means there's a much higher risk of direct ocular involvement, keratitis, uveitis, serious eye problems.
So nose tip rash equals high alert for eye complications.
Exactly. It's a strong predictor. Definitely warrants an urgent ophthalmology referral if you see it. Don't dismiss it as just a spot on the nose.
Good tip. Okay, so the presentation seems quite characteristic, especially with the rash pattern and maybe Hutchinson's sign. How is the diagnosis usually confirmed? What investigations are done?
For the most part, HCO is a clinical diagnosis. The history and the classic signs, the unilateral dermatomal rash in V1, the eye symptoms are usually enough.
Based on what you see and hear.
Pretty much. But if the diagnosis is uncertain, maybe the rash is atypical, or in, say, an immunocompromised patient where things can look different, you might do further tests.
Like what?
You could take a swab from one of the vesicles, the fluid inside, and send it for viral culture, although that takes time. More commonly now, you do PCR polymerase chain reaction.
To detect the VZV DNA.
Exactly. PCR is very sensitive and specific for VZV DNA. You could also do immunofluorescence on a scraping from the lesion base.
Okay.
But importantly, regardless of lab tests, a thorough eye examination, including checking visual acuity, looking closely at the cornea, checking eye pressure, that's absolutely vital in the diagnostic workup.
Right. Assessing the eye itself is key. So once it's diagnosed, what's the management strategy, say, here in the UK?
Treatment needs to start quickly. The mainstay is oral antiviral medication.
You mentioned those earlier.
Yes, typically acyclovir, valacyclovir, or fanciclovir. They work by stopping the virus from replicating further.
And that helps.
It reduces the severity and duration of the rash, helps with the pain, and crucially significantly lowers the risk of developing those serious eye complications and also postherpetic neuralgia.
Okay.
Yeah.
How long is the course?
Usually for 7 to 10 days. And the key thing really is starting it early.
Within that 72-hour window you mentioned.
Ideally, yes. The benefit is greatest if started within 72 hours of the rash onset. After that, the benefit might be less, but it's often still given, especially if there's ongoing vesicle formation or eye involvement.
Got it. What about other treatments? Pain relief?
Absolutely. Pain management is crucial. Simple analgesics, sometimes stronger neuropathic pain agents if needed. For the eye itself, lubricating eye drops can help with dryness and discomfort. Sometimes specific medicated eye drops are needed, but that's really under ophthalmology guidance.
So referral is important.
Urgent referral to an ophthalmologist is essential if there's any sign of eye involvement, pain, redness, blurred vision, light sensitivity, or that Hutchinson sign.
Urgent referral. Okay.
In very severe cases or for significantly immunocompromised patients, intravenous antivirals might be used in hospital.
And topical antivirals, like creams.
Generally not recommended or effective for the skin lesions in HZO, unlike in, say, cold sores. However, topical corticosteroids, steroid eye drops might be used by the ophthalmologist to control inflammation inside the eye, like uveitis or keratitis, but never without specialist oversight and usually alongside antiviral cover.
Okay, so oral antivirals are key. Prompt treatment, pain relief, and urgent eye referral if needed. What's the likely outcome? What's the prognosis?
With timely and appropriate treatment, the prognosis is generally good for most people. The rash heals, the acute eye inflammation settles.
That's good news.
It is. However, complications can occur, and they can definitely impact the long-term outcome.
Such as?
Well, corneal scarring is a big one. If the cornea gets badly inflamed or ulcerated, it can leave scars that permanently affect vision.
Leading to vision loss.
It can, yes, ranging from mild blurring to significant vision loss in severe cases. Secondary bacterial infection of the skin lesions or the eye is another risk.
Okay.
And then there's the one we mentioned, postherpetic neuralgia or PHN.
That lingering pain.
Yes, persistent, often debilitating nerve pain that continues for months, sometimes even years, after the rash itself has completely gone. It can be very difficult to treat.
Wow, that sounds really impactful.
Yeah.
Are there other specific complications we should be aware of?
Yes, there's quite a list, especially relating to the eye. Think about the different parts.
Okay.
You can get inflammation of the surface, conjunctivitis, keratitis, episcleritis. Dupper inflammation like anterior uveitis is common.
Inflammation inside the eye.
Exactly. More serious things can include corneal ulcers, which can perforate. Glaucoma, raised eye pressure can develop. Cataracts can form later on.
Right.
Even potentially blinding conditions like retinal necrosis, though rarer. And you can get palsies of the nerves controlling eye movements, leading to double vision or ptosis, a droopy eyelid.
That's quite a range of potential eye issues.
It really highlights why specialist eye assessment is so vital, remembering them. Maybe group them. Surface inflammation, internal inflammation, pressure issues, lens issues, nerve issues.
That grouping helps. Surface, internal, pressure, lens, nerves. Okay, so let's try to quickly summarize the absolute must-know points for someone revising HZO.
Okay, HEO. VZV reactivation in the trigeminal V1 distribution.
Affecting forehead, eye area, nose. Risk factors.
Yeah.
Definitely age and immunosuppression, plus prior chickenpox.
Key sign. Painful unilateral vesicular rash in that V1 dermatome. Watch out for Hutchinson's sign on the nose, big red flag for eye involvement.
Diagnosis is often clinical, but PCR can confirm VZV.
Management. Prompt oral antivirals. Acyclovir, valacyclovir, famciclovir, ideally within 72 hours. Plus pain relief.
An urgent ophthalmology referral if any eye symptoms or Hutchinson's sign.
Absolutely critical. Prognosis is generally good with treatment, but beware of complications like corneal scarring, vision loss, and especially postherpetic neuralgia.
And those other eye issues, keratitis, uveitis, glaucoma.
Yeah, the list is long. Prompt treatment minimizes the risk.
Excellent summary. So maybe a final thought to leave our listeners with, something to ponder about HDO.
I suppose it really underscores the link between systemic health, immunity, and localized viral reactivation. It's a reminder that viruses can lie low for years and cause significant trouble later, especially when our defenses are down. And specifically for HCO, never underestimate a rash near the eye. Think HCO, look for Hutchinson's, and act fast.
Great point. That connection between immunity and reactivation is key. Well, that wraps up our deep dive on HCO. Hopefully that's given you a clear, high-yield overview for revision or just for understanding.
I hope it was useful.
And if you're prepping for the MSRA or want more resources like this, do check out pastthemsra.com.
And also freemsra.com for free questions and resources, too.
Perfect. Thanks for tuning into the deep dive. We'll catch you next time.